Ready? We're going to give another 1 to 2 minutes.
Renee and Jana, just let me know when the entries are slowing down.
Hey, LJ, if you're okay with it, I see that Connie White's on the call already. So if you don't mind, if we could start that access conversation, if we could start the meeting with that access conversation for imaging. LJ, can you hear me? Not looking good. Can you hear me, LJ?
Renee, we
Yeah.
can't hear you.
You can't hear me at all?
No.
I can
You
I can hear you.
Yeah, I can hear you. I can hear you perfectly.
I
Can you
think
hear
they
I
couldn't.
didn't hear you. Yes. How do you like that? It was very fun. You were like, it was funny because it looked like you were doing charades. And I thought, what a fun meeting this is going to be.
I just wanted to ask you, LJ, that since we have Connie on the call already, can we start with the conversation about imaging access?
Yeah, absolutely.
Hi, good afternoon, everyone, and thank you for inviting me. I also have Dr. Eric Weinberg, who is the Vice Chair of Clinical Operations for Imaging on the line as well. And I do believe that Tom Murray, who's the Clinical Operations Director for Imaging at Strong, is also going to join us. I'll cut right to the chase. Appreciate everyone's frustrations with access to imaging, especially in what we call the northern region, and that's the Rochester area. We have hit the perfect storm, if you will, in terms of additional demand for imaging from many sources, the Wilmot Cancer Center and some of our other specialties, as well as a critical nationwide shortage of radiologic technologists. And I think it's safe to say that that really is the root cause of most of our access issues. We have added multiple modalities. We're upgrading our modalities for greater efficiency, but we don't have the staff to fill the spots that we have expanded into. And one example of that is we created a business improvement plan for what was University Medical Imaging. That's at Clinton Crossings, Building D. Adding a multitude of CT slots in the evenings and the weekends. And we've not been able to start that operation. And it's been 10 months now since that was approved. We don't have the staff to fill it. Travelers, the travel agencies over the course of the last 18 months, unfortunately, have recruited several of our staff away. I know that's not unique to imaging. It's the same thing has happened with nurses across the enterprise. I am the regional administrator and liaison to FF Thompson, all the way down to Jones Memorial, with Noyes and St. James in the middle. I've been working with Dr. Chad Teeters and his leadership team. We've added additional slots for CT and PET down to Noyes and are trying to shunt patients down there to the ability that we can if they are in proximity and able to travel. That's just a few of the things that we're doing. I see Tom has joined. Tom, chime in whenever you want. Tom's been working very closely with MCC and Kathy Perinello and Steph Von Bacco and Ed Strong in expanding the class sizes of the incoming radiologic technology program. So that's kind of it in a nutshell. I'm going to hand it over to Dr. Weinberg and Tom to see if you'd like to add anything, and then take any questions you may have.
I apologize for the delay, everyone. Tom Murray, Clinical Director for Imaging Sciences. Thanks for giving us a few minutes. Just wanted to let you know that we are also in the process of, we received approval to expand operations at UMI for CT into the evenings and the weekends. Sorry, Connie, if you already mentioned that. Clearly, the challenge right now is staffing, finding the candidates to fill those roles. We estimate right now that due to staffing, somewhere in the 300 outpatient exams per week are not being honored as a result of that. In order to address some of those issues, we are working with compensation right now to create what we refer to as a travel at home program, so we can continue to retain our staff. For anyone who might be looking to go into the travel industry, we're going to create an arrangement where they can stay here. Again, Connie mentioned some of the longer term options we have with MCC in the support of expanding their class sizes. But the fact is we need help now. We've got dedicated recruiters that we're starting to press to start advertising our positions a little more broadly, trying to go beyond the Rochester area to see if we can attract technologists, nurses, et cetera, so that we can again expand to the extent we need, because the community is telling us that they need more access, and we're working very hard to try to provide that access. So thank you.
Yeah, I can just make a brief comment. I'm Eric Weinberg, Vice Chair of Clinical Operations. I recognize a lot of your names here. I've worked in the outpatient realm most of my career. I understand, what the pressures are and the concerns. We are, as my two colleagues have said, taking really positive steps to try and improve the situation. I can speak to one of them that's in process right now, and that's particularly as it relates to MRI. We've really substantially invested in new MRI technology. We're just at the beginning of it with the first few machines online. They're substantially faster, which really means that we can get more patient throughput, which will hopefully should reduce backlogs. But at the same time, we're also seeing surging demand. As much as we expand, that tends to get used up pretty quickly. So we'll just keep doing the best we can and follow along the plans as outlined by my colleagues.
There's a comment in the chat regarding the difficulty folks are having getting someone even on the phone to answer the phone for scheduling. Can you speak to that, Connie, your imaging team?
I think you're muted, Connie. I can't hear you.
How about now? Can you hear me?
There we go.
Yes.
Sorry, I apologize. Yes, we appreciate that we have extremely long hold times. Part of the issue is that we, again, have a depletion of staff within our central scheduling. We are actively recruiting and interviewing for 7 open positions. We have also started to initiate some alternate means of scheduling, whether it be by a list that one of the practices sends us to schedule all their patients via the list. We've embedded and trained up schedulers within some of our larger refers. For instance, the Wilmot Cancer Center is is ramping up operations so that their staff can schedule directly into our schedule. Obviously there's guardrails around the templates that we provide them, but that has been successful in several areas, and we continue to expand that. So we're adding staff. We're trying to schedule outside of the box, and we're actively working on it. I know this does not help you and your staff, but this is a #1 priority for imaging and the imaging leadership team. We talk about it every day in our leadership meetings. What can we do today, moving forward? So it's got the attention of everyone up to Vicki Hines, Kathy Perinello, Steve Goldstein, Dr. Rotundo. Everyone knows we're struggling here, and we don't have a short-term silver bullet to solve everyone's problem, but we continue to work it aggressively.
Connie, we appreciate your team coming into this. These originally were calls that were focused on COVID changes and responsiveness, and we have been repurposing them in order to be able to feature concerns from our practice teams. facilitate better connection and communication between many of our practitioners who are in independent practice with the broader URMC and Goss Center Children's Hospital. So we appreciate your willingness to come. I have one follow-up question before we let you go. And when you talk about these changes to scheduling that are being considered, how will our partners, who are many of whom are represented on this call, who are in independent practice but utilizing and referring to UR medicine, how will they hear about those? I understand the initial focus on some of the big places like the Cancer Center, but how will they find out about that?
Well, I'll work with Renee on communication. I think that would be the first next step. I'm sure our team are more than happy to update you via this forum. We do a similar update with the Wilmot Specialty Service Line meetings that are monthly. So I guess you tell us how you'd like to communicate. We'll provide the information for you.
That's great. Thank you very much. I don't see that there were any other questions in the chat on this specific issue, although a reminder about staff using the Rio to get reports rather than making a phone call. We understand that. Excellent.
And I would just say, add on to that, LJ, as we understand that a number of other access issues in other areas of URMC have been brought to our attention, and we do intend to invite reps from those areas to come to this meeting as well. We've heard about orthopedics, we've heard about urology, I think a lot of the challenges that Connie and her team described are pretty universal, but there might be some additional information that'll be helpful for you. So we are working on getting those folks lined up. So just want to let you know that we did hear your feedback on those other areas within URMC, and we're doing our best to get those folks lined up.
Thanks, Renee, for summarizing that. So and labs reopening are a question that's in that mix, as in the chat. So we will report out on all of those things and gather information for our next call. So you recognize we're missing someone on the call today. For those of you who are regular attendees, Dr. Teeters may end up slipping in here at the very end, but we think he's actually in a meeting that he probably will not be able to step away from. So we've assembled a team to be able to report in on the other items that are on the agenda. So I'm going to take us back, and we're just going to talk COVID for a little bit and just do kind of a brief report on where we are and where things are going. So as we look at sort of our current state right now, I'm sure that most people are aware that we're fortunately at the moment, we're in a relatively low transmission risk zone, but the incidence does appear to be rising. We recognize that the newest strains is close to 50% or more of our strains now are BA4 and BA5, and that keeps changing by the week, increasing in terms of the BA5 strain. We recognize, like, the take-home message is it's easier to transmit, it's easier to catch. I mean, that's a very simplistic version of this. But it is now the most commonly, BA5 is now the most commonly transmitted strain in the US. That is informing a lot of work around what will boosters look like in the fall, all things like that. We recognize that the fall boosters, the leading booster candidate, is showing high neutralizing antibodies against these strains. But there is a concern that we see a surge before those boosters are available. So in that kind of continuous catch-up game that we have been in for a while. I think that the other thing in terms of messaging around this that's really important to know is that, the same measures in terms of what is your best protection against these strains is still the same, whether they're more highly transmissible or not. So doing all the same things that we've talked about from forever. Good hand hygiene, masking, being careful about closed spaces with close contacts, being very careful about eating around other people. I mean, we need to be mindful of it's the same measures, whether people like them or not. It is the same protective things that we should be keeping in mind and we should be reminding our patients about. I think we're going to talk a little bit more about boosters and vaccination, but I wanted to start out first with giving the The pharmacy team is present, and I'm not sure how long they can stay on. So I want to come back to that issue, but give the pharmacy team a chance to talk a little bit about Paxlovid and some changes coming about in terms of the prescribing of that. And then just in case they can't stay on, we'll go back, we'll talk about what's coming in terms of boosters and then some of the other things on our agenda. So Bob, I wonder if you want to take over?
Sure. Thanks, LJ. I'll just share my screen. Or it looks like it's already being shared, so we're good to go. Thanks. And for those that don't know me, my name is Bob Adams. I'm the new Director of Pharmacy Services for AHP. And just wanted to bring your attention to a new update, a new EUA that was released by the FDA on July 6th. And go ahead and go to the next slide. And so on July 6th, they released an update around Paxlovid. And it was also presented at a meeting, a weekly meeting on COVID-19 therapeutics held by the Health and Human Services and ASPR. And during that meeting, you can go ahead and go to the next slide. They discussed that what has changed is they are now allowing state pharmacists to prescribe Paxlovid as well as dispense it. And there is information in these slides that are following coming through are the ones taken directly from the weekly meeting with HHR. And what we like to say is that there's sufficient information. There's some bullet points here that will be helpful in describing the process. And it boils down to the pharmacist having access to 12 months of the medical record, sufficient information about the patient's medications and their labs. And you can go to the next slide. So if the patient is tested positive, the pharmacist has access to all their 12 months of records, access to the medications, access to labs. It allows them to prescribe. And you can go to the next slide. So what this means for us and for the community at large is that in the coming days and months that there will be the ability for pharmacists to prescribe the medication and dispense it. Now, these prescriptions and dispensing will occur at locations that are called test to treat locations. In the Rochester community, the only area that has access, the only available site for this is Trillium at this point. So there is still a lot of unknowns if this will be ramped up into the outpatient areas like CVS or Walgreens, if it'll be expanded to those areas as well. But right now, there's only one location within the 50-mile radius, and that's the test and treat location at Trillium. Now, whether they have started implementing where pharmacists can prescribe, that hasn't happened yet. There's a lot, this information is new as of July 6th. So there's a lot of information and collaboration that's ongoing. Our own pharmacy leadership team out of URMC is also taking this information in, looking at the opportunity to provide this service to our community. The goal of this is to expand access for our patients. And there are a lot of questions, whether, how this will roll out, how this will take place, what is the information that pharmacists will have access to. And so it will continue to evolve in the next, month or so as more information and more details are being put forth. But I just want to let you know that this came out and something that the community may be talking about and you may hear more of.
Thanks, Bob. Are there any questions we have on that? All right, I appreciate that information from the
Team. So, so what I want to do is just take us back for a minute and just talk about boosters because I saw some questions that were coming up in the chat. And just give me 1 minute because I managed to minimize you all somehow, which is interesting. You're all still there. I just found you. I thought, oh, am I talking in just dead air? So, so just reminders, obviously COVID vaccination for children under 6 years of age was approved and updated as of June 18th, 2022. That the recommendation is everyone ages 6 months and older receive a COVID-19 primary series vaccination. We have information on the website about the various dosing recommendations depending on whether or not Pfizer or Moderna is chosen. I want to just highlight again that the majority of our primary care practices now are vaccinating children. as well as the young children, as well as the older kids. I give a ton of credit to our practices that are doing this. This is extra work above and beyond the work that you to stand this up. And for some of you who are actually vaccinating others in the community as well, you like a huge shout out because that is even more work. We are there are 2 sites now within Monroe County, Golisano Children's Hospital, that is providing vaccine for patients outside of the practice anywhere in the region. And they have vaccine clinics that are scheduled and available on Wednesdays and Saturdays. All of the information is updated on the website. And we have just learned that Acute Kids of Webster is also offering, they have offered vaccine in the past for older kids and are offering vaccination for younger kids. So if you have patients that you're not able to see, if you're still standing up your processes for this and need to refer, that is another resource for you. We're learning from many of you and from reports that are coming in around the country. While we're not seeing any reported rates of vaccination for this age group yet, it's somewhere between around 5% of kids appear to be vaccinated at this point. And there's a lot more hesitancy, again, for many families about starting the vaccine with their 6-month-olds. We're hearing a lot of families wanting to wait until potentially the fall before they will vaccinate, seeing how this initial rollout goes out. And the AHP just put out some information stating that 60% or higher of families will follow the guidance of their primary care providers. So it just reemphasizes the importance of having those trusted conversations. Even if someone's not ready to vaccinate yet, they may be in time. And so being able to have that conversation with your family physician, your pediatrician, your nurse practitioner is really key. So thanks everybody for your work in that space. And let us know if you have questions or concerns or need help if you're still standing up vaccine. In terms of boosters, basically CDC clinical considerations were amended to state that everyone ages 5 and older should get 1 booster after completing their series. And then in terms of a second COVID-19 booster, definitely for people ages 12 and older who are moderately to severely immunocompromised, and for those ages 50 and older. And I think I highlighted very briefly that the very contagious subvariant BA.5 is it's just so much more readily infectious that people are not going to have the same protection from having disease acquired immunity and vaccine acquired immunity, but vaccinating is really important, and we will be waiting to see when the new vaccines are coming in the fall, and it'll be very important to prioritize those. I think that's pretty much what I have in terms of vaccine and COVID information. What I'd like to do is shift for a moment now to talking about other things that are on the agenda. Renee, do you want to talk a little bit about the, go ahead,
Sure.
you were unmuted.
Can you hear me?
Yes.
Okay, I think there's a Zoom issue, but anyway, and LJ, I don't know if you saw the document I had sent to you or not, but just a couple more things on the booster of just the specific to the subvariant. Is that the FDA is directing manufacturers to add the necessary develop vaccines that add the spike protein component of the subvariant to create a 2-component booster vaccine that should be available in early to mid-fall 2022, and that they begin clinical trials. So the FDA is really pushing manufacturers to get going on upgrading the booster. And then on other COVID news, I just wanted to, I'm sure folks have seen this in the news, the lawsuit, the results of which are regarding to New York State quarantine and isolation procedures. On Friday, July 8th, the New York State Supreme Court Justice ruled that Rule 213, which establishes isolation and quarantine, was in violation of state law and therefore null, void, and unenforceable. The Rule 213 was enacted as an emergency regulation in February of 22, and it's been renewed every 90 days since then. And that just gives the authority to the health commissioner to direct local health officials to issue isolation and quarantine orders. That was deemed that the issue with that the commissioner had the power to force anyone into isolation or quarantine despite a lack of evidence that a person's infected with COVID-19. And there's no word yet on whether this ruling will be appealed, but I imagine that it likely will be. So there'll be more to come on that. And then for the topic that LJ does want me to talk about, which is grand rounds, switching from COVID world into our more regular course of our work at AHP, we're excited to announce that we will be having a fall clinical grand rounds. I believe we did put this in our most recent network news. This is save the date, and I'm just trying to re-up that information here. It's going to be Wednesday, October 19th. It's still going to be via Zoom. All of our adult and pediatric PCPs are invited to attend. We're going to have a joint session together on a topic of mutual interest, and then we will break out our adult and pediatric providers into separate breakout rooms to hear clinical content appropriate to their area of specialty. So we'll be getting out more information about what's on the agenda in the coming weeks, but we do ask that you please hold that date Wednesday, October 19th at 5:30 p.m., 5:30 to 7 for our fall clinical grand rounds. I think that's all you wanted me to talk about.
Yeah,
right?
that's great, Renee.
And I
Thank
think
you.
Jana has a quick mention of something as well.
Yes, two quick mentions. The first is, given that there are now vaccines available for kids 6 months and up, we've updated the pediatric toolkit that folks were able to utilize to help stand up vaccine clinics in their offices. So if you are still in the process of doing that and you would like some additional information, a little bit of guidance there and some best practices from other members in the network, that is up, and we'll make sure we link to it in today's update. The second is we still have multiple unused, unopened boxes of gloves in our office. They are size medium. So if any of your practices are looking for some free PPE, we have those available for you. And then we also have face shields available. So if you would like to get in on either of those, you can shoot me an email. And of course, that will also be in today's update for anyone who missed it.
Thank you, Jana. I'm seeing Elizabeth Murray. Elizabeth, is there anything you wanted to update people on around sort of status of disinformation?
Status, oh my God, I'd love to come up with a new name for it, like status informaticus. I don't know. Anyways, lots of rhetoric about with the FDA now giving full approval to the vaccine for 12 and older. This has gone around before, but that how somehow unless you have the vial that has the brand name on it, you're not giving an approved vaccine. It's like a vaccine versus, I'm sorry, brand name versus generic silliness. So everybody, I think, already would know how to speak towards that. There was a military lawsuit about the vaccine in which it was a civil complaint. So the summary by the judge is quite large. You know, they go through all of the information that was presented and then make their ruling. Their ruling was that what the plaintiffs brought about mandating the vaccine was unfounded. So the court sided with the military, saying that the vaccine should be given to those people. But within the document, the plaintiffs presented some information, again, to try to make everything confusing about brand name versus the EUA labeled vaccines. And so that was mentioned. And since it was mentioned in the summary findings, some are saying that proves that they're different vaccines, which is not the case. So again, if you hear talk about there was a lawsuit that proved it, that's not the case. The other thing is, I just want to clarify the booster thing. I'm looking at the CDC website right now, which says it was updated on July 11th. And the wording specifically says is you may consider delaying your vaccine by 3 months from when symptoms started or a positive test. But I've never seen except for the very beginning, anything specifically saying you have to delay. But I'm hearing from parents that they're being told that they have to delay boosters until 3 months post disease. But I'm just a little confused on that, because I thought it was you could, but you don't have to. So New York State is now saying that you should? Because that doesn't make sense, especially.
It doesn't make sense either. Let's clarify that one. We'll go back and clarify that, because my understanding is the same as yours, Elizabeth, that it recommended, but it could be done as early as they're out of that acute
Right, it's very clear, like you have to be out of isolation
Mhm.
and your potential quarantine period, but not 3 months.
Thank you. So just as we get ready to wrap up, I'd like to look ahead a little bit to the fall also. We talked about fall grand rounds, but I'd like to, for those of you who care for children, who have children, who care about children, as we think about going back to school, I'm sure all the pediatricians and family physicians who have managed all of the crazy protocols and testing and return to school stuff are wondering what is it going to look like for the fall. And I do not have an answer, but we will have an answer for you. So we have been in contact with the former schools reopening safely task force. We've got calls out to the state, the county, the American Academy of Pediatrics, looking at the cardiology, the cardiac guidance, the return to play guidance. And so we will be sure you'll know when we can give that information. I'm realizing we may need to hold a separate noontime session towards the end of August. I'm alerting Renee right now to that because I bet we will not have all the information on hand. What we're hearing right now is like, I don't know. We don't know. We don't have anything new yet. But clearly, if the protocols are going to be the same, you all need to know that. And we will be working hard to try to advocate for things to be as clear as possible. But as you can tell from this call, it all just keeps circling back around. This has never been a clear thing. Just keep your focus on your patients, your staff team, yourselves. And one little bit of bright spot for those of you who care for kids in the RCSD school district. They've done a really nice streamlining plan. You saw it in our agenda. It will be in our messaging that goes out today, but they have now one fax number for those of you who are doing school physicals for children RCSD. There is one fax number to send that information to. They will route it to the appropriate district, and we're hoping that this, or appropriate school, and we're hoping that this will allow for less confusion. There's a lot of children in our CSD who don't have completed forms, who have had physicals done. And rather than them trying to go back and redo physicals on all those children, they're trying to assure a better, more streamlined form of communication. So if you can enter this into your electronic records where you do internal faxes or alert your staff, that will be great. And it will be in our messaging today. And I think that wraps it up. Were there any other messages in the chat that weren't answered? I wasn't looking at the chat.
Looks like one from Toby. Now that the vaccine is approved, do we still have to have patients do the complete vaccine questionnaire in agreement?
Toby, I don't know the answer to that, but I would say yes, I would do it until we hear otherwise, because I think that's in your best interest. I think it assures, full consent. And especially with a vaccine where there's been so many questions about, I think it's wise to complete that. That would be my impression. Okay, good. We thank everybody for joining today. We'll have a summary going out in our email messaging. We will plan to see you again in August for our next meeting, but we'll update you with other information as it comes through in the meantime. And then potentially there'll be some type of a forum for schools before we go back in September. Thanks, everybody. Have a great day.